So the first question is lignocaine dilution, complication, contraindications and uses. So lignocaine is a local anesthetic that belongs to the amide class of local anesthetics, and it is one of the most widely used local anesthetic agents. Its various concentrations are used for various procedures, and for example, it is a prototype amide, which is a very popular anesthetic, and it can be used to control severe pain and post-herpetic neuralgias also. So a mixture of lignocaine, that is 2.5% lignocaine, and prelocaine 2.5% as an eutectic mixture, that is EMLA cream, is used for skin anesthesia, that is it can anesthetize intact skin and used for procedures such as venesections or cannulation in children. Lignocaine as an infiltrative agent is also used in 0.5 to 1% lignocaine for local anesthesia for minor procedures like incision and drainage, suturing, and for topical anesthesia. As also, lignocaine is used in spinal anesthesia in 1.5 to 5% concentration for surgery of lower limbs and lower abdomen, perineum, and cesarean section. As an epidural anesthesia, 2% lignocaine is used, and which is for obstetric analgesia also. For Beer's block, that is intravenous regional anesthesia, lignocaine is used in 0.5% concentration for upper limb and lower limb surgeries. Then that's all for the concentration for lignocaine used. Then the complications. The complications of local anesthesia may be CNS excitability or bradycardia, hypotension, which is more common in bupivacaine. Allergic reactions, that is skin rashes, itching, erythema, urticaria, bronchospasm. Mucosal irritation, which is more common with cocaine and prelocaine, but may be seen in few cases of lignocaine also. Contraindications for use. Contraindications, there are no such contraindications for use of lignocaine, but if it is used with an adjuvant that is a vasoconstrictor like adrenaline, where vasoconstrictor reduces its uptake, so the duration of action is increased. So contraindication with use of vasoconstrictor is in areas where there is end arterial supply like pinna or lip surgeries or digital interventions where reduced arterial supply or reduced blood supply may lead to gangrene or hypoxia or tissue hypoxia. Trauma management. First, we will discuss about airway management and then about the pneumothorax management. So, in case of airway management, it is the most vital parameter because if the airway is not intact, that is if there is no patent airway, the patient may suffer from hypoxia. So cervical spine stabilization is the first thing that we maintain, and if the person is able to talk, then we will suppose that the airway is intact and move further with the management of other parameters. If the airway is compromised, we move forward with intubation, or if there is an emergency where intubation is not possible, then tracheostomy is performed. And an emergency tracheostomy is performed by needle cricothyroidectomy, and an elective tracheostomy is done under with insertion of a Y connector and a tracheostomy tube. For intubation, we use the endotracheal tube with a cuff so as to so as to prevent aspiration. The cuff is inflated once it is in the airway. So if there is aspiration of gastric contents, it can be prevented. The cuff it is also a low pressure, high volume cuff so that there is no local necrosis of the cartilage and the trachea. What to do for securing the airway? First of all, we will remove the tongue. That is, if the tongue falls onto the airway, it may block the airway and lead to a compromising condition. So we put the patient in a lateral decubitus position so as to move the tongue out of the way, and also so as to prevent any aspiration a lateral decubitus position is preferred, so as all the oronasal secretions or the gastric secretions move out, or the vomitus can be removed from the way. If the person has nasooral bleed or a bleed from the nose or any oral from the oral cavity, so suction of the oral secretion is performed repetitively so as to prevent any aspiration until we secure the airway with an endotracheal tube or tracheostomy. Breathing. Then moving forward with the pneumothorax management. Pneumothorax is an emergency condition. In an emergency condition, we perform a needle thoracosynthesis, and for the definitive management of a pneumothorax, we perform tube thoracosynthesis. Needle thoracosynthesis in adults is performed by using a wide bore IV needle and inserting the needle in the fifth intercostal space in the mid axillary line. And for children, we use the second intercostal space in the mid clavicular line. Insertion of the definitive management, that is tube insertion. The intercostal tube is placed in the triangle of safety, and the previous wound, that is the sucking wound, is covered with a gauze with a tape on the three sides so as to make a wall and prevent the re-entry of air on breathing. That is, the air can escape but cannot enter the cavity. In a simple pneumothorax, there is no hemodynamic compromise, so we may manage the patient with needle insertion, or that is also not even required. It resolves spontaneously. But in a condition like the hemothorax, where there is blood in the pleural cavity, or we can see blood, or we can see air fluid level on a chest X-ray, on a supine chest X-ray, and there is decreased cardiac output, decreased systolic blood pressure, and the heart rate is increased. So we place an intercostal drain in such conditions in the triangle of safety. For emergency management, if the patient is not managed by these measures, then there is emergency thoracotomy advised. That is, if there is more than 1.5 liters of blood after the chest tube placement, then it is advised to go for emergency thoracotomy so as to relieve the pressure inside. If there is more than 200 ml of blood repeatedly for 3 consecutive hours, then we move forward with thoracotomy. If there is a condition of cardiac tamponade, thoracic aorta injury, tracheobronchial injury, or an esophageal rupture, we move forward with a emergency thoracotomy. And emergency room thoracotomy, in which we have to provide open cardiac massage, or is there is a massive air leak or there is massive bleeding, their emergency room thoracotomy is conducted. But this procedure has a very high mortality rate, and it is an absolute procedure which is performed under grave conditions. That is, there are no other methods left, then only we perform an emergency room thoracotomy. Chest tubes are placed in the triangle of safety. The boundaries of triangle of safety are anterior axillary fold in the anterior position, posteriorly by the posterior axillary fold. Apex is the axilla, and the base is the fifth intercostal space. Anywhere in this region we can insert the chest tube. All the holes of the chest tube must be inside the chest, the thoracic cavity, and it is the other end is sealed with an underwater seal so that the air can escape but cannot enter back again. The position of the chest tube may be confirmed by chest X-ray, and when the output is more than 10 ml in 24 hours, or the breathing sounds are present on the affected side of the lung, and or on X-ray we can see that the lung has expanded totally, then we can remove the chest tube. The next question is the doses of chloroquine for malaria treatment. Chloroquine is a mainstay drug. That is, it is used for treatment of uncomplicated malaria caused by Plasmodium falciparum, ovale, vivax, malaria, and novelty. The dose of chloroquine is 600 milligram base oral on the first day, single dose stat, followed by 300 milligram per oral at 6, 24, and 48 hours. The treatment of chloroquine resistant Plasmodium is with artemether and lumefantrine, in which artemether is 20 milligrams and lumefantrine is 120 milligram. 4 tablets are given at 0 and 8 hours, followed by 4 tablets every 12 hours for the next 2 days. the doses of all TB drugs. As per the new guidelines, the NTEP guidelines that were conducted in year 2022, the regime is 2 HRZE plus 4 HRE. So the dosage for 2 HRZE will be the isoniazid is given for as a daily dose. Isoniazid is given as 300 milligrams. Rifampicin is given with 600 milligrams. Pyrazinamide is at 1500 milligrams, and ethambutol is at 1000 milligrams. For the continuation phase, that is 4 HRE, we will give isoniazid 300 milligrams, rifampicin 600 milligrams, and ethambutol 100 milligrams. Dog bite management. The mainstay treatment for dog bite management is the wound management. That is, we will wash the wound under running water. Then we will take care. We will administer. We will control the bleeding. If there is excessive bleeding, we will control the bleeding. Administer a tetanus shot and provide antibiotic cover. And if required, the wound will be the suturing of the wound will be performed. As for concern with ARV, that is anti-rabies vaccine, is given. Depending upon the severity of the dog bite, it can, if there is a superficial dog bite, then we can give the rabies vaccine on the 0, 3, 7, 14 and 28 days of the dog bite. And also, if though not practiced much practically, but the vaccine is also poured onto the wound also sometimes. Some practitioners prefer this, that they will break the ampule and pour the vaccine on the wound itself. But the vaccine is delivered at 0, 3, 7, 14 and 28 days of a dog bite. The wound is managed with an antiseptic solution after the dog bite immediately, and the 5 doses are completed. It is advised not to consume alcohol while on the medications. Ascites. Ascites is presence of more than 25 ml of intra-abdominal or intraperitoneal fluid, which can be due to various reasons. The mainstay treatment of differentiation, if assessed by parasynthesis, is SAAG index, that is serum albumin gradient. If it is a high SAAG, then it is due to increased hydrostatic pressure, that is, there is increased extravasation of fluid into the cavity. And if it is due to low SAAG index, that is, there is high protein in the peritoneal fluid, that is, the ascitic fluid is high in albumin, it is due to some other organic cause. Differentiating on the basis of clinical assessment, if there is high hydrostatic pressure and if there is presence of melena or portal venous hypertension, then there will be variceal bleeds will be present. The patient will give history of melena or hematemesis, and black colored stools we will relate likewise. If there is very less fluid present, that is, which is not enough to distend the abdomen, then we will look for shifting dullness. Shifting dullness is a condition because of which, when fluid is present in the peritoneal cavity, the air filled bowel loops will float upwards, and on percussion, if the patient lies supine, on percussion, if we begin from the flanks down to up, there will be dull sound present due to the fluid filled abdomen, and as we move upwards at the top, we will find tympanic note due to air filled bowels. And when we will position the patient laterally, the air filled bowel loops will move towards the higher lateral side, and the fluid will move downwards toward the flank. So on moving from down to up in the lateral position, there will be dullness, but as we reach on the upper flank, there will be a tympanic node present. This is known as shifting dullness. And if the fluid is high enough so as to fill up the flanks, we can notice the abdominal distension by the naked eye. And if it is tense ascites, fluid thrill will be present, that is, we will tap with our finger on one of the flanks, and the thrill will be transmitted by the fluid towards the wave of the fluid will be transmitted towards the other flank and can be felt on the examiner's hand. Other clinical diagnostic criteria will be the presence of dilated abdominal veins whose blood flow can be checked to determine the direction of the venous stasis. Spider nevi may be present, which may indicate liver cirrhosis, and parasynthesis is performed repetitively so as to reduce the abdominal distension and relieve the patient of the general symptoms. After parasynthesis, the fluid is assessed for SAAG index, and if it is a high SAAG, it will be due to either portal hypertension or Budd-Chiari syndrome or cirrhosis. Whereas if it is a low SAAG index, that it may be due to a peritoneal tumor, that is a metastasis of tumor, or nephrotic syndrome, or any other or pancreatitis may also be the cause. Absolute contraindications of intrauterine devices. Absolute contraindications of intrauterine contraceptive devices according to WHO category 4 will be a case of puerperal sepsis, or dysfunctional uterine bleeding, an ongoing PID or STD, cancer of cervix or cancer of endometrium, gestational trophoblastic neoplasia, or any uterine fibroid. These are the absolute contraindications of intrauterine contraceptive device.